very much. May I then invite the board to move on to the next item, which is the NHS performance report. And please, Barbara, may I invite you to introduce it for us?
Thank you, Chairman. I'd like to do three things, both through the report and through what I say in the next 10 minutes or so, 5 minutes perhaps, for you. One is to report the performance of the NHS. Secondly, to reiterate and give you assurance on a range of actions that we've got in place with our partners in NHS improvement to ensure that performance remains the best it possibly can be, and to ensure that we're resilient, especially for the winter. And thirdly, if I can, to go on and give the board some specific updates and assurances about the actions we've got in place for our emergency planning role, particularly in the light of the still potential junior doctors' action and the events after Paris. So if I can start by reminding the board that these figures demonstrate just how busy the NHS is, and now immediately we have hundreds of thousands of staff out there in the NHS dealing with seeing patients who are very busy indeed and very stretched. And we've got thousands of patients within NHS England and within our colleagues in NHSI doing everything they can at the national and regional level to support them. The numbers are disappointing. They will show that there are significant numbers of standards for care for patients that we've set that we're not quite reaching. But I will reiterate, as I do in every board meeting, these are small drop dips below the standard we've set ourselves, and the vast majority of patients in England, whether they're having emergency care or planned elective care, are seen within the times, seen or treated within the times or standards that are set for them in the Constitution. But nonetheless, this is still a particular effort of focus to us, because we know that for patients out there, then what matters to them is that they can be seen quickly by their general practitioner, and effectively they can be seen quickly and efficiently if they need an ambulance, if they need to call 111, if they need to go to the A&E department, and where they have planned care, that those arrangements can be made for them at a time that suits them and where they don't have to wait. And we continue to focus really hard on these day-to-day operational issues which are so important for patients. I think that our particular focus, and I'll therefore go first to urgent and emergency care, is to make sure that we are really resilient both for the Christmas period and for the worst of winter, which, particularly looking at today's weather, is certainly going to get worse than it is at the moment. The report includes a number of high-impact changes and a number of areas where we're helping the service, but I think we need to focus on a number of specific issues, making sure that those high-impact changes are implemented in every health economy across the system. We've got the emergency care intensive support scheme working with 28 health economies, sharing best practice, helping them to put in place all the systems and processes which will maintain the flows through hospitals, make sure that patients who don't need to go to hospital and can be treated in the community are treated out in the community. A particular focus on delayed transfers of care. You'll notice in the numbers that specifically the social care transfers of care are rising, and this does give us a problem. The patients who this is not good for patients, because if you don't need to be in hospital, people don't want to be. They want to be back in their place of residence, even if that is in the long term to be a residential or care home. So we are putting a particular focus on how we can help not only with the NHS delayed transfers of care, but working with our colleagues through DH in local government and social services to try and minimise the number of delayed transfers of care because of social services. We have identified 55 health economies where we're particularly worried about the pressure on them around emergency care. And we're working very closely with them, as I say, again, with our colleagues in NHS Improvement. And one of the things we've determined to do is to say to those health economies that they should consider the slowing down, or they should in fact indeed slow down the elective care that they're offering to patients through late December in the run-up to Christmas and over the Christmas period, simply because what is critically important is that we have absolute resilience for urgent and emergency care. This is not just about the numbers and the standards, although they are important because they're a barometer of what we're doing. It's making sure that the NHS is prepared for the peaks and troughs, the spikes when we get sudden surges in need for emergency care. And at those times, we can absolutely guarantee that all patients will be treated safely. So for those 55, as I say, we have conveyed to them that they should reduce their elective care, and I think it's important to report to the board that on that basis we must assume that the referral to treatment target, the 18-week target for December and January, is not going to be achieved, exacerbated to some limited extent by the junior doctors' threatened action, which I know it was called off, but a significant number of operations were cancelled in preparation for that. And I think when you add all that together, our determination to focus on emergency care, make sure that patients get safe services over the holiday period and immediately afterwards, means that we will see some dip in the standards for elective care. Moving on to those standards for elective care, what I think is important to say, though, is that we need to see this as a temporary reduction, and our focus on this particular standard in the longer term is no less determined. It was a really hard-won fight over many, many years to ensure that patients waiting for elective care were treated quickly and swiftly. And I think it's important to reiterate that it's not that many years ago that some patients died while they were waiting for heart surgery, that patients went through years and years of disability waiting for joint surgery, patients spent years waiting for cataracts when they couldn't see. And over the years, the NHS fought really hard to make sure that we had a really strong standard. I can't remind people, it's not 18 weeks till you get seen by a consultant. It is 18 weeks from the day you are referred to the date at which your definitive treatment is in place. This is a great standard. The vast majority of patients still receive this standard. In fact, the median time is even much shorter than that. But whilst we need to focus on emergency care over Christmas and the early New Year, we will be coming back really strongly with NHS improvement in 2016 to make sure that we get back up to speed and that we get back to achieving that referral to treatment target. Cancer is so important to everyone. Really good news. You'll note from the report that all the standards have somewhat improved. We're not achieving all of them, but we're making good progress with a lot of initiatives in place. Pleased to report to the board that our mandate for dementia, which was the 62/3 target, was delivered in November. So we've done well on that, and that we are still seeing a lot of initiatives around the recovery process on IAPT. We've achieved the access standard, but we want to see more patients who receive IAPT being assured of recovery. So lots of work still going on that. So finally, Chairman, if I can just take the opportunity to talk about emergency planning, which I think, again, is so important. This board has a very specific role when should an emergency arise. And most of that role is about being prepared should the emergency arise, and the huge amount of work that goes on a day-to-day, week-to-week, year-to-year basis to make sure that we in NHS England and the whole of the NHS, because our responsibility is that the whole of the NHS is absolutely prepared should any sort of emergency arrive. I commend everyone in North Cumbria, where people within the NHS have had to put in a very significant extra effort to help support the problems that there have been there. We're focusing now specifically on two areas. As I said, the junior doctors' potential action. Need to remind people that potential for action still exists, and therefore we are using this extra time if we have it, much though we hope that negotiations will mean it's not necessary, the extra time to make sure that we're thoroughly prepared. Bruce and I chair a specific oversight group to look at how we deal with any action that might come about. We were reassured by the plans we got in when we thought we had potential action for December, in that even at the prospect of moving to the place where the junior doctors withdrew their support for urgent and emergency care, when we looked at the returns we got from all the trusts across England, a very small number were reporting that they would have difficulties, particular difficulties where they couldn't continue to deliver safe services for patients should that happen. Now, obviously, through our colleagues within NHS Improvement, they've been continuing to work with those 7 trusts to make sure that they can, and the number is now much smaller, that they could provide these emergency care services. We've done a number of things nationally to try and help everyone. There's a document which we will be putting on our website, hopefully within the next couple of days, and we'll go into the BMJ about the various good practice issues that you could do under those circumstances in order to support services outside hospitals to make sure patients don't go there if they don't need to, and services within hospitals to make sure that they can be more efficient should we have strike action. But what we will do, of course, in the event that strike action it does come back again, we will need to go around again, because the small number of trusts were having problems. Some of it was in the context of that time. Some of it was because for example, one particular trust had had an outbreak of norovirus just before we received the returns. So we need to go back around, because actually the information we need from the trust has to be absolutely up to date, and we'll continue to do that. In terms of the unfortunate events in Paris, I do need to say, because this is important, that the risk level as defined by the Joint Terrorism Advisory Committee for us is unchanged, but that doesn't alter the fact that on the back of the sad events in Paris, we've really redoubled our efforts and focus to make sure that we're prepared. I think our immediate learning from Paris was about gunshot wounds, and Bruce and his team, Keith Willett et al., have done a huge amount of work in identifying, working with the experts around the country, making sure that we are in a better position clinically to deal with such an episode where there are significant gunshot wounds. Again, I remind the board that we took part in an exercise, a cross-government exercise, Exercise Strong Tower, which I reported to you a couple of times ago, which was specifically about a marauding terrorist attack. So we do have recent events of a very specific exercise which was undertaken in London. But as I say, the early learning from Paris has been specifically about gunshot wounds. What we've also done is written to all provider responders, so all the acute trusts and our local resilience forum. I wrote to them all saying, would they please ensure that they reviewed all their processes. They're doing this anyway, because this is the time of year when we're collecting all the evidence, so we can come back to you as a board in March to give assurance that we have all bases covered on emergency planning, but redoubling their efforts and reviewing that, particularly around Cascade, particularly around ensuring how they would be able to get all the relevant clinical staff into the hospital quickly. Looking at that where there might potentially have been access or transport problems. A particular focus I asked them to do was on prolonged critical care, because from Paris what's become apparent is that you need a much more prolonged ability to provide critical care for a high number of patients, and as I've said, around ballistic injuries. The letter, of course, also went to ambulance trusts, asking them to just redouble their efforts and make absolutely sure that their teams who are they have teams specifically for marauding terrorists and firearms, and they have teams specifically for hazardous substances, making sure that they were absolutely resilient on those. And this is on a day-to-day basis. This is the kind of thing that we look at on a 12-hour basis to make sure we're always up to speed. We will continue to learn lessons from Paris. Many of them will be cross-government, so there's a big piece of work that we're involved in with the Department of Health and other cross-government, which will look at things like logistics, communications, transport, and all the things that have come out of that. But that, working with the French government, that will take many weeks and months to get the full learning out of that. But we'll make sure that as any learning comes through, if it applies to the NHS, we will relay that to our frontline staff to make them even more prepared.
Well, thank you, Varney. That's a very comprehensive and in many ways quite troubling report, but thank you for the assurance that you've been able to give us. Let me invite any questions from around the board table. Kieran, please.
Back to 2.2 and 2.3, attendances at A&E up 0.6%, admissions up 2.1%. Is it the patients who are different, or is it how we look after them that's different?
I think what the Philander is that they are seeing sicker, we've got an ageing population, they are seeing sicker patients and more of them need admitting. I think that we've started to do quite a lot in the community. There's, we've just a lot of communications to try and persuade people not to go to A&E if they don't need to. In a lot of places, the 111 service is really helping and directing patients to primary care rather than to A&E if they don't need to be admitted. So I think what we're beginning to see is our A&E services protected for those patients who really need them. But I think what we're not yet doing sufficient of is making inroads into the number of patients who need to be admitted. And for that, we need to get more upstream in the community. And this is one of the particular worries for us over Christmas and New Year. And a plea we would want to make to patients is that often over the Christmas and New Year period, frail or elderly patients, they don't like to be seen to be a trouble. They think that the surgeries aren't open over that period and that the doctors and the hospitals are very busy, and they therefore wait and they get iller. And then when we come back in the New Year or in the gap in between, then these patients who might at one stage have been able to be dealt with at home need to be admitted to hospital. So there's still a lot of work to do, but this is really a reflection of an ageing population and a population for whom we can do much more.
But if that trend goes forward, it's kind of 3.5 times more admissions to additional people turning up, and if you extrapolate that forward through the 5 years we've just been talking about, that's quite a big problem.
Well, we have done, and that's what's in the base case for the demand modelling, offset by the changes that we want to introduce. So nothing about this that is inconsistent with the decisions we've just taken. In fact, the rate of growth in emergency admissions so far seen this year is lower than we were planning for.
Okay.
Simon, would that also be true of the growth in delayed transfers of care, which is the most staggering growth in the whole of this document?
No,
That's putting
I mean,
huge pressure
I think
into
as Barbara
the
says,
systems.
it is putting pressure. It doesn't, I don't think you can sort of juxtapose the two and say QED, therefore we've got what we're seeing showing up as pressures in providers, and there are some other things going on there as well. But the detox issue is obviously a canary down the mine on the social care issue and the need for integration and joint working. And I think we've got more work to do, frankly, to kind of really land the right incentives between health and social care on that question. And there is quite a lot of discussion going on nationally on that topic.
I think it needs to be seen in perspective, because the number of patients we discharge every day compared to the ones that are delayed, it is still a relatively small number. And as well as working with social colleagues, we need to redouble our efforts in the NHS, because some of the delayed transfers of care are because we haven't got necessarily the right intermediate or community care beds or the right services in the community. Sometimes that's because those patients in our intermediate community care beds are waiting for social care beds or care in the community. So it really is a whole system approach, and it does matter. If we can, it matters to patients. It's not just about the beds and the fundings. It matters to patients to be able to go home, and have to go home or to their place of care and have the right arrangements in place for them.
Absolutely. Any further comments and questions? Yes, Margaret.
With the improving access to psychological therapies, paragraph 2.26. Sorry, I think my mic was down. Can you hear now? Is that better? Can you hear?
I think so.
Is it in connection with paragraph? That's better, thank you. Paragraph 2.26, the IAPT paragraph. You've referred to the fact that we're working on reducing variation in recovery rates with certain supports given to the lowest performing IAPT providers. And I was just wondering whether, as a board, there was something that we could track that would, in particular, focus on the fact that this is linked to high levels of deprivation. And I was quite keen to see that we could actually help to monitor some degree of improvement in that you are talking about some of the hardest to reach people in that category, And I was just wondering whether there was some metric that we could be monitoring.
I certainly don't think we've done that, but Bruce's team oversee IAP for us, I think, and of course the operations team help with the numbers, and we could take that back, couldn't we, Bruce, and have a look and see.
Thank you very much.
Right. Well, thank you very much, Barbara, as always, for that very clear report. And I just ask the board please to note the report and take assurance from it that we've identified where there are risks, we've identified where performance is weak, but we've also heard of the mitigation measures and particularly, Barbara, the steps that you are proposing to support the service through the holiday period and in the event of any emergency, which calls on our emergency resilience capacity. Okay, thank you very much.